Welcome back to Pharmacology for Vocational Nursing 2. This week we're going to talk about the anti-epileptic drugs. There will be more than one audio lecture in this series, so let's get started. In order to understand the anti-epileptics, let's talk a few minutes about epilepsy. So epilepsy is a syndrome of central nervous system dysfunction, and seizure symptoms vary depending on the area of the brain that's being affected by this activity. It is the most common neurological illness, and it results from this electrical activity that's excessive in the neurons that are located in the superficial area of the brain, or in the gray matter. When we have a seizure, there's a brief episode of abnormal electrical activity in the nerve cells. Now, sometimes people use seizure and convulsion interchangeably, but they're really not interchangeable. A convulsion is the involuntary spasmodic contraction of any or all of the voluntary muscles throughout the body. That includes the skeletal and the facial muscles. So you could safely say that all convulsions are seizures, but not all seizures result in convulsions. And so therefore, they're not really interchangeable terms. Now, epilepsy occurs when we have this chronic, recurrent pattern of seizures. Of course, it's important for the provider to have information about the type of the seizures, the recurrence of the seizures, in order to plan the treatment options. But the symptoms can range from like a muscle twitching or a slight tremor of a limb to a sudden violent shaking and a total loss of consciousness. Could also be staring into space, altered vision, and difficult speech or other behaviors that a person could have during a seizure. The methods of classifying seizures, or classifying epilepsy, have changed over time. And so we'll talk about that in just a few minutes. But when we look at epilepsy, there's the primary or the idiopathic, and the cause cannot be determined. Now, this is more than 50% of the cases of epilepsy and seizure activity. So when we look at the secondary causes, we can find a distinct cause. It could be something like trauma, maybe a physical trauma like a blow to the skull, a chemical trauma, like the presence of toxic substances or the ingestion of poison. It could be a cerebrovascular disorder, like a change in the oxygenation when we have respiratory hypoxia or carbon monoxide poisoning. Maybe there is a cerebrovascular accident or a cardiac dysrhythmia. Also, metabolic disorders like changes in the fluid and electrolyte imbalance. Pediatric disorders, when there's a rapid rise in the increase of body temperature, they can have what are called febrile seizures. And the overall incidence for febrile seizures is about 2%. So when we look at these types of seizures, we can see a distinct cause. Now, I said earlier that the classification has changed over time. And that's because we've learned more about seizures and we've become more informed about the brain itself. The former terms have been replaced with more descriptive terms. So what you'll find is that general onset seizures, as the names suggest, are not localized to one area but travel throughout the entire brain on both sides. And the seizure is thought to originate bilaterally and symmetrically within the brain. We formerly called these grand mal seizures. Also, general onset seizures include tonic-clonic, where that's the most common type. They are preceded usually by an aura, and there's intense muscle contractions indicating the tonic phase, and then the clonic phase is characterized by an alternating contraction and relaxation of the muscle. So these usually last about 1 to 2 minutes, after which the patient becomes drowsy, disoriented, and sleeps very deeply. We could have aclonic seizures. You'll also hear these called atonic seizures and sometimes drop attacks. So what happens is the patient will stumble and fall for no apparent reason. It lasts for only a matter of seconds. The episodes are actually very short. We could have myoclonic seizures, and the myoclonic seizures are characterized by large jerking body movements. The major muscle groups they contract quickly, and the patient appears to be unsteady and clumsy. They may fall from either a sitting position or they may drop whatever they're holding. In an infant, myoclonic seizures may not be recognized as seizures because they often appear like a normal infantile startle reflex. Now, absence seizures occur most often in children, and they last for only a few seconds. Because they're short-lived, they're very difficult to detect. Absence epilepsy often goes unrecognized, and so it can be mistaken for daydreaming or signs of attention deficit disorder. They may stare off into space or have a temporary loss of responsiveness. There may be some slight motor activity with eyelid fluttering or repetitive jerking motions, but these can also be difficult to diagnose. The partial onset seizures were formerly known as, or the simple ones were formerly known as petit mal or petit mal. These are seizures that involve a limited portion of the brain. So it starts on one side, and the activity, the abnormal electrical activity, then only travels a short distance before it stops. So you could have what are called simple partial seizures, and they have small limited focus. They may feel disoriented. They may hear and see things that are not there. Sometimes patients smell things or taste things that are not there. Other times they can have an emotional response, like a sense of joy or sorrow. Their arms or legs or face may twitch a little bit. Then there are complex partial seizures. These were formerly known as what we would call psychomotor seizures or temporal lobe seizures. They have a sensory, motor, or an autonomic symptoms, and so there's not usually a total loss of consciousness, but there's a brief period of confusion and somnolence that can follow the seizure. These seizures are often preceded by an aura, and it's sometimes described as an unpleasant odor or an unpleasant taste. They may start with a blank stare, or the patient may begin to chew or swallow repetitively. Sometimes patients may fumble around with their clothing. Most of them will not pay attention to any type of verbal command if you're trying to help them. They do not remember the seizure after the fact. Then, of course, because we are human and none of the two of us are alike, even identical twins, we can have unclassified seizures where they don't really fit into these neat little categories that we have. You have this visual in your textbook, which shows you a description that helps you maybe discern the difference between the old classification and then the new classification of the seizures. When we look at Statusepilepticus, now this is where we have multiple seizures. It's a medical emergency. It's a true medical emergency because the repeated occurrence of these seizures can result in severe hypotension, hypoxia, and brain damage, ultimately leading to death. There's continuous muscle contraction occurs. They're also going to become hypoglycemic, acidotic, and hypothermic because of the increase in metabolic needs, lactic acid overload, and the heat loss during the muscle movement. So that carbon dioxide retention will lead to the acidosis, and if not treated, ultimately the patient will die. Medical treatment in this instant always involves IV administration of anti-seizure medications. So we have to make sure that the airway remains open as well. The anti-epileptic drugs now are also known as anticonvulsants. So the goal of therapy with all of these drugs is to control or actually to prevent seizures while maintaining a reasonable quality of life. The effective management of seizures involves a strict adherence to a safe drug therapy. We want to minimize the adverse effects and the drug-induced toxicity. Anti-epileptic therapy is usually lifelong, and a combination of drugs could be used. The choice of the medication is going to depend on things like the patient's age, their signs and symptoms, their previous medical history, any other comorbidities or associated pathologies. And once a medication is selected, they're usually placed on a very low initial dose with the amount gradually increased until seizure control is achieved or until the adverse effects of the drug prevent additional increases to the dose. Often serum drug levels are required, and we need these to help in determining the most effective dose and monitoring for toxicity. If the seizure activity continues, this is where we might add a different or an additional medication. Again, with small increments, gradually increased. Because seizures are very likely to occur if an anti-seizure or an anti-epileptic drug is abruptly withdrawn, these medications are usually discontinued over a period of 6 to 12 weeks. Now, as I said, single drug therapy is usually started before two-drug or multiple drug therapy is tried, and serum drug concentrations must be measured. So we want to do this with medications like phenytoin, phenobarbital, carbamazepine, levetiracetam, and primidone, because they correlate better with seizure control and toxicity than do those of valproic acid, ethosuximide, and clonazepam. So these anti-epileptic drugs are traditionally used to manage seizure disorders, and the ones that we usually see are the barbiturates, the hydantoins, the immunostimulants plus valproic acid, and then we have second and third generation anti-epileptics. Their mechanism of action must prevent the generation and the spread of excessive electrical discharge from abnormally functioning nerve cells, while at the same time protect the surrounding normal nerve cells. The exact mechanism for most of these is not known, but the anti-epileptics are thought to alter movement of the sodium, potassium, and calcium ions across the nerve cells in the brain. So if you look at the mind map that you have available, you will note that we have an anti-epileptic drug that is a little note there that says rare antidysrhythmic use occurs. This is when we have tried all of the other antidysrhythmics and we need something to help the patient. So we may try this anti-epileptic because of the sodium potassium pump and the calcium ions across the cells of the heart. Not the usual use, but just know that sometimes these drugs are used for other purposes. We'll talk about that in more depth in just a few minutes as well. Now, the overall effect, regardless of the mechanism of action, the overall effect that we're achieving here is that the neurons are stabilized, the neuron hyperexcitability is decreased, and the spread of this excessive nerve impulse is decreased, thereby reducing the seizure. The anti-epileptics are indicated for the prevention or control of seizure activity, long-term maintenance therapy for chronic recurring seizures, the acute treatment of convulsions and Statusepilepticus, and then some other uses. For example, we found that although seizure medications were originally designed to help people with epilepsy, they have some nerve calming qualities. So they've been used to help patients with migraines and nerve pain. And so they've extended beyond the capacity of just epilepsy. So we also see them used in ADHD, borderline personality disorder, and PTSD. Let's take a break, and then we'll come back and talk a little bit more about these drugs.